Hi everyone. Being the last speaker is always difficult. It's hard to follow on from the great speakers we've had this afternoon. I'm just going to do a quick 10 minutes on practical tips of strain analysis in infiltrative cardiomyopathies. So strain is still a pretty hot topic. There's over 1,000 publications each year on echo and strain at the moment. And strain is just deformation of the myocardium. So basically it measures regionally or globally the length of a segment in diastole minus the length of the segment in systole divided by the length of the segment in diastole. So that's the overall principle. It just looks at the deformation of the myocardium during the cardiac cycle. Now there's 3 types of strain which are based on different motions of the myocardium. There's longitudinal strain, circumferential strain, and radial strain. And the interesting thing is that the different layers of the myocardium are more or less involved in the different vectors of deformation. So if, for example, the subendocardial layer, where the fibers are longitudinal, is very involved in the longitudinal strain. And the longitudinal strain is what's been the most studied. And the main value of strain is that it's a very sensitive index of myocardial function. And in many pathologies, it decreases earlier than the ejection fraction and seems to have better prognostic value. So in measuring strain, we're going to follow 7 easy steps. First, we acquire the appropriate images. Then we assess the quality of the image to perform the strain analysis. We want to really observe where the annulus and apex landmarks are. We trace the endocardial border. We adjust the region of interest width, making sure we don't go into the pericardium. We check the quality of the tracking, and then we repeat steps 5 and 6 until you're happy with the quality of the tracking. The images we need are the apical 4 chamber, the apical 2 chamber, and the apical 3 chamber, or the apical long axis. And we need to acquire these images, making sure the endocardial border is clearly seen throughout the entire cardiac cycle, so adequate tracking can be performed. When we acquire these images, we need to make sure we have a frame rate greater than 40 frames per second. We need to really optimize the blood tissue border and make sure we have a good ECG tracing. In patients in atrial fibrillation, we need to save at least 5 beats and acquire beats with similar R-to-R intervals. Now we usually start with the apical 3 chamber image because this is where we see the aortic valve. And we mark the basal posterior annulus, then the basal anteroseptal annulus, and then the apex. And then we just let the software automatically track the endocardium. If we're not happy with the automatic tracing, this is where we can manually do some corrections. After that, we need to mark the time where the aortic valve closes at the end of the T-wave. And this is going to let the software know where the beginning of diastole is. We then repeat the tracking with the apical 4 and the apical 2 chamber, and the software will automatically show you the bullseye plot, which is really useful to see the different patterns of abnormalities. So let's just look at some common mistakes that can be made when measuring strain. Which one do you think is incorrect? And I think I just heard you all say the first one was incorrect, and that's right. We can see that the annulus is marked too deep into the left atrium, and it should be anchored at the insertion of the mitral valve leaflets. So tracking into the left atrium is going to give us a falsely low strain value. And which one here do we think is incorrect? Of course, it's the first one. Tracking the anteroseptum into the left ventricular outflow tract will also give us a falsely low strain value. And this one is a little bit more difficult to see, but it's tracking too deep into the apex and tracking the pericardium. And it's a common problem when the apex isn't optimized, and it'll also underestimate the strain value. And our final one is a little bit difficult to see also. It's a bit grainy, but we can see it's the first one, and it's tracking the papillary muscle. And we need to be mindful of incorrectly tracking anatomical structures like the papillary muscles or trabeculations. So how is strain useful in helping diagnosing infiltrative cardiomyopathies? Well, when you see the typical findings of cardiomyopathies on conventional echo, strain's usually not needed, but it does add a bit of oomph to the diagnosis. Because the longitudinal myocardial fibres are located predominantly in the subendocardia, reduction in strain can be found before the ejection fraction is reduced. So what can strain add? Well, in amyloid, we see the reduced strain in all the basal and mid segments and relative sparing of the left ventricular apex. This is a sarcoid heart, and because sarcoid is a granulomatous disease affecting the myocardium, we normally see reduced strain in the basal and mid interventricular infraseptum, as well as in the inferior wall. And in Fabry's disease, reduced strain is normally located in the lateral posterior walls, which again is beautifully demonstrated in this bullseye plot. So in summary, we need to first of all obtain the best possible images, watch the wall motion before tracing, mark the annulus and apex correctly, adjust the region of width, avoiding the pericardium, and avoid tracking any anatomical structures. Thank you very much for your time.